I'm Donny. So I'm a professor at the University of Nebraska and chief of ophthalmology at the Children's Hospital. And Dr. Serena Wang is a associate professor at the Southwestern Medical Center in Dallas, Texas. And we have a very exciting program prepared for you. First, I would like to take a quick question. I am blank, please. I'm going to give you 10 seconds. So we're going to have 5 questions, and I would like to know who we are talking to. We have 1,700 participants registered today. So we have mostly general ophthalmologists, and we have optometrists and pediatric ophthalmologists, and then we have other specialists. Okay, next. Is a timing of surgery. When do you perform unilateral cataract surgery? At birth, or just wait till 2 weeks, or 2 to 6 weeks, or 7 to 8 weeks, around 2 months of age? Number 5 is around 3 months of age, 9 to 12 weeks. So if it, I'm going to give you 10 seconds. And these questions are based on the questions that were requested on the survey. And it looks like most perform between 2 to 6 weeks, which is actually pretty consistent with what I do. Okay, next, I would like to ask timing of bilateral cataracts. So if it's a bilateral cataract that's visually significant at birth, when do you do the first eye? I know in some countries they do both eyes at the same time, but for this question, like when is the time of the first cataract surgery? At birth, less than 2 weeks, 2 to 6, 7 to 8, 9 to 12 weeks. For bilateral cataracts, the answer, it looks like it's about the same. 2 to 6 weeks is the earliest, is the most common, and then 7 to 8 weeks, okay? At what age do you try to place the IOL in congenital cataracts? For unilateral cases, again, the questions are never, right at birth, or if the 7 to 12 months, 13 to 24 months, and then greater than 2. Or do you just prefer no IOL? Again, perfect. So most people place it if they're greater than 2. So they leave them aphakic, it looks like, till 2 years of age. Okay, great. Next question is that if for the bilateral cataracts, when do you place the IOL? Never, from birth to 6 months of age, 7 to 12 months, 13 to 24 months, greater than 2, and preferred no IOL for bilateral cases. So this is a question for visually significant cataract and for those who perform the cataract surgeries. And the response. So again, the response is pretty dominantly. 58% says greater than 2 years of age. Okay, great. All right. So just in general, this is what I do. Again, there's no right and wrong answer for the unilateral dense congenital cataracts. For the most part, I think I do between 4 to 10 weeks of age for healthy babies, and of course, if there's any medical problems that would require delay, then we may have to do it later. The studies have shown that the risk of glaucoma with earlier cataract surgery is higher if it's performed less than 4 weeks of age. So that's the reason why I try to avoid cataract surgeries before then. And for the bilateral dense cataracts, it's between 2 to 3 months. And I usually wait only about 2 to 4 weeks between the cases. Bilateral surgery on same day is typically not recommended, but in certain countries where the cost and the risk of anesthesia is high or is not available, is not readily available, then they would have no choice but to perform the surgeries on both on the same setting. And this does happen even in this country. In terms of the surgery, the success truly depends on the planning. The planning is the most critical part. And because a lot of things can happen with these congenital cataract surgeries, and the danger is always lurking. And things can happen very, very quickly, as you all know. And with the proper planning, you can avoid these disastrous situations. So the planning makes you avoid you playing with fire. So we're going to talk about the planning. So when you plan these surgeries, you have to modify the surgical technique based on what you're dealing with. And what are some of the things that I think about when I'm looking at the cataracts? I look at the anterior chamber depth. Is it deep enough for me to be able to perform the surgery? Would I have to deepen it? Am I going to be able to place the IOL? So the size of the pupil. I have very low threshold of placing pupillary dilators, pupil dilators, iris hooks, or whatever that's required to dilate the pupil, because I think, in my opinion, the most important part of the cataract surgery in pediatric patients, like in adults, is the anterior capsulotomy. And if you don't have a good view of the anterior capsule, the surgery could become disastrous in a matter of a second. And is the eyeball big enough? Where is the location of the cataract? Where is the opacity? Is in the posterior capsule? Is in the anterior capsule? Is in the nucleus? Am I able to see the posterior capsule and appreciate the posterior lenticonus? So when I hydrodissect, is the posterior capsule going to be strong enough to withstand that pressure? Is there a significant trauma that affected the zonules? Is there significant anterior segment dysgenesis? Is the iris healthy enough? Is there posterior synechia? And I look for anatomical abnormalities. And after reviewing all these things in my mind, then I develop a surgical plan. The important thing is that whatever you plan, you have to keep it simple. Steve Jobs said, if you can get there and keep it simple, you can move a mountain. And I firmly, firmly believe this. You want to keep it as simple as possible. The poor prognostic factors include unilateral cases, because the treating amblyopia for these patients can be somewhat challenging. So the visual outcome may not be as good as for the bilateral cataracts. Smaller eyes, whether it's a microphthalmia or persistent fetal vasculature, they tend to have a worst prognosis because there's a significant anatomical abnormality. And then associated with ocular abnormalities like the Peters anomalies and systemic disease in patients, for example, with a juvenile idiopathic arthritis with inflammation. For the surgical consideration, placing an IOL or no IOL, this is a big concern. This is one of the questions that many of you brought up. Relative IOL contraindications include children with chronic inflammatory disease such as JIA. I used to be a lot more daring 20 years ago when I started working. So if the patient was under control and there's absolutely no inflammations within 3 months, I used to put IOL. But now I think I tend to be just a little bit more conservative. That 3 months went to 6 months and 9 months. And now I'm at a point where if there's any signs of, if there's any history of significant anterior uveitis, I tend to not place IOL. Of course, there are other mitigating factors, but I tend to go against the IOL placement. But what are some of those mitigating factors? I'm going to talk about that in a little bit. And if the eyeball is less than 9, if it's a 9 millimeters or less, then I typically do not place IOL. IOL considerations, if they're unilateral cases, I tend to put the IOL sooner than later because these patients, you're going to have to deal with anisometropia. And with a significant anisoconia, you're increasing the chance of amblyopia. If they have nystagmus, contact lens is going to be difficult. Dry eyes in patients with the keratoconjunctivitis sicca or any other type of significant dry eyes due to different metabolic disorders or different autonomic dysfunctions, I tend to consider placing an IOL because contact lenses is going to be very difficult. If they live in a dirty, sandy living conditions, like for example, Northern Africa, where it's very windy, there's a lot of sand in the air. So those patients, I tend to lean toward placing an IOL. Limited access to contact lenses. In some cases, at some places around the world, the aphakic contact lenses, the Silsoft, and those lenses are not available, or the cost is limiting. So those patients, in those situations, I would place an IOL. Compliance concerns, behavioral issues with ADHDs or autism or other type of developmental delays, and cost and follow-up if it's an issue, IOL I tend to put in. So IOL, typically I place them in 7 months or older because the studies have shown that there's a higher need for repeat surgery, not so much complications, but for repeat surgeries if it's performed less than 7 months of age. With the fibrosis of the anterior, for the anterior hyaloid of the vitreous, resulting in repeat vitrectomy or repeat surgeries. So I typically do not place IOL anyone less than 7 months of age. If the corneal diameter is less than 9, I do not. But in some situations, like the mitigating factors that I just showed you, the PCIOL lens diameter is 8 millimeters. So you can potentially remove the haptics and place just a lens inside the bag. And that I've actually seen that happen when I visited India. And 3, IOL calculations dilemma. How to measure axial length and what formula do you use and what power do you aim for? So this is actually some of the common questions that I was asked. So I just wanted to spend just a few minutes. Conventional ultrasound biometry, applanation versus immersion technique, and optical biometry. For pediatric patients, most commonly we use applanation technique because it's most convenient and it's accurate if it's performed by the trained biometrist. But you have to make sure you don't compress the cornea when you do this. So you really have to have the excellent technique to do this. Immersion technique is perfectly acceptable. The optical biometry is typically not performed in pediatric patients just because of the, many of them, we actually have to put them to sleep because we cannot perform the axial length and keratometry in an office setting. Remember, 1 millimeter error in the axial length calculations result in 3 diopters of refractive errors, either depending on which direction. But if it's a short eye in pediatric patients, that error, every 1 millimeter, you're going to be off by 3.75 millimeter, 3.5 diopters. So that's pretty significant. So you got to be very careful. 2 school of thoughts. Do you aim for emetropia or low power IOL? This is just a matter of preference. But emetropia is if you plant a 28 diopter producing emetropia at 8 months of age, this will most likely result in -7 by the age of 3. So this is a pretty significant myopia you're going to have to deal with. And see, you're basically committing these patients to most likely contact lens fitting for the rest of their life. So these are some of the things that you have to think about. So what I typically do, this is a target refraction that I aim for, somewhere in between, somewhere in this range. So typically, 1, I do 6. Just remember the number 6. 6 minus 1, so I go for 5 diopters. So 2, 6 minus 2 is 4. So that's what I go for. So I subtract the age from 6, and that's that's pretty close to the approximation, but that's the table that I go by. Formula, I pretty much use SRKT. There's no one formula that's far superior than the others, but typically Hoffer Q in a very short axial length, in a baby with a very short axial length, I use Hoffer Q, but SRKT is what I use. The cause of, but you do end up with refractive surprises, and I've had my share. There are many reasons out there, but I would say this is one of the biggest one. Is a posterior staphyloma that you may have overlooked, and if you aim the ultrasound when you're performing the ultrasound biometry, and if you miss that small posterior staphyloma, you may get a number that's that may not be optimal. Surgical techniques. Dr. Wang's going to go over this a little bit more in detail later, but like I said, removing the anterior capsule is truly, I think, in my opinion, is the most critical, because that kind of sets the tone for the entire surgery. The capsulorhexis is difficult. It is truly difficult, and it's different than adult patients. Why? It's thinner, elastic, and it has more convex. It's more convex shaped, and it tears easily because it's thin and it's more elastic, and it's got a radial force. And the anterior chamber is shallow in a smaller eye, and then also the sclera is less rigid with a low IOP. So as you're manipulating the tools, it tends to collapse and blur your vision easily, and then you don't get that nice bright red reflex on retroilluminations, because most of these congenital cataracts are visually significant and they have white cataract. So what are some of the tips? As you all know, we have a dispersive and cohesive types of viscoelastics, and the cohesive, so for example, the Hilon GV, those are the ones that's heavier, that's more cohesive property. As you can see here, it's more of a gelatinous consistency. So it tends to form the interchamber better, so it makes the surgery easier. However, it tends to be a little bit more expensive, and it is not readily available around the world. So most people that are performing these surgeries they have to resort to the dispersive OVD, which I think works just fine. It's like once you get the hang of it, I think it works well. And the Trypan Blue, not only it stains the anterior capsule, but it does make it, I do think, slightly stiffer. I don't know if I truly believe that. I don't know if I truly believe that, but maybe it's just a psychological factor. But I do think that it does make the tear just slightly easier, consistent with the literature search. And so this is what you want to end up with: something somewhat circular intercapsulorhexis, about 5 millimeters. The adult lens, I just want to show you, it's fairly flat. The interior surface is fairly flat. So when you're trying to perform the tear in one direction, there's a counterforce that's going in opposite direction. So it is actually, when you're trying to tear a paper, you actually need counter traction and attraction. For example, like this. It actually, that counter traction has to go in opposite, completely opposite, 180 degrees in opposite direction for you to make that tear. However, in pediatric patients, the anterior surface is pretty convex. So when you're trying to make a tear in one direction, there's a counter traction, but also there's another force, a radial force that's going toward the equator, toward the center of the lens. So that's why the net vector force is actually slightly in a diagonal fashion. And that is the reason why it is very easy for you to go and tear into the periphery toward the equator. So the direction of the pull should be about 45 degrees. 45 degrees in this way. If you do it 90 degrees, it actually makes it you can end up with the capsulorhexis that's just too small. So what happens when you do 45 degrees is that the tear, you want to go in this direction. So, excuse me. Okay, anyway, so you want to go 45 degrees because to counteract that radial force. The lensectomy, make sure you move all lens cortex with the because they tend to have a vigorous inflammatory conditions. And posterior capsule management, I typically remove posterior capsule if I cannot perform the YAG laser within 1 year. So if they're less than 5 years of age, or if they're not going to be cooperative with the laser, I go straight to the posterior capsulotomy and anterior vitrectomy. By the way, it is not advisable to just remove the posterior capsule without removing the anterior vitreous. I do know that people do that, and I do think that at least in my experience, the anterior surface of the vitreous tend to pacify pretty quickly in those situations. YAG problems, the problem with the YAG is that it does tend to recur. So it is not unusual for you to use a YAG on the same patient 2 or 3 times. When you're doing the posterior capsulotomy or capsulectomy with a vitrectomy, the ideal diameter of the anterior capsulotomy is 5 millimeters in diameter, because remember, the lens diameter, the PCLL diameter is 6 millimeters. So if you make the anterior capsule opening bigger than that, there's a chance of prolapse. So you want to make it ideally 5 millimeters. The posterior capsule opening, the ideal diameter is about 4 millimeters. You want to make it slightly smaller so that you don't have any problem with the lens dislocating. And understanding when you are doing the surgery, understanding the surgical equipment is extremely critical. And Serena is going to talk about that for the next 20 minutes, and then we're going to talk about we're going to address many of the questions. Thank you. Go ahead, Serena. Go for it.
Well, first of all, thank you, Donny, for arranging this webinar. I'm happy to be here to share my surgical technique, my instrument with everyone. You may find that interesting because it's slightly different. I developed my way to do pediatric cataract surgery for past 15 years. So I think cataract surgery can be uncomplicated. Okay, here's my starting slides. Pediatric instrument and technique I have kind of developed over the years. Go through lots of complicated way, and I finally figured out this easy way for me to do it and make things uncomplicated. Hope some of you can think that's interesting. Here's the first slides. This is my cataract tray, surgery tray. Not very complicated, only a few things on there. After we remove those knobs for microscope, that's all we have. So I'm going to go through each of them, and also my surgical videos, see how we do those uncomplicated pediatric cataract surgery. Here, this is the lid speculum I like to use. You know, people use like different ways. This one's small. It works even for the very small children, like the newborns. And this is called Alfonso without tap. Here's my this is 0.12 forceps. I always have 2 in my tray because those are very important, essential instruments for pediatric cataract surgery. I think we really can take advantage of general anesthesia. You can actually hold the eye instead of the eyeball wobbling around. So like Dr. Suh just talked about the counter force, 180 degrees away, you hold eye. You can keep the eye really steady and make your surgery much easier and controlled. I use this 0.12 forceps to that. Here's some knives I use, and you can see the first one is we call it super sharp blade. This just we use for paracentesis. The second one is 2.5 millimeter keratin. I use this for my bag lens, the SN series for the in the bag lens. Then this is a bigger knife, 3.5 millimeters. I use that for Focus lens or 3-piece. We need a slightly bigger incision for that. Here's some picture of the knives. I don't know what brand you use. The principle the same, the size matters. So here I want to show this important instrument I like to use. Don't know if you can see this. It's called the micro-incisional capsular forceps. Here we go. This very important instrument for me. I have been using this for past 15 years. Make a capsule erectus is so much easy and controlled, versus you make a big incision to try to do this. Because this macro incision forceps make your anterior chambers very stable, which is pretty much the key for pediatric cataract, especially infantile cataract surgery, because their eyes very soft, very bouncing, unstable. If you keep your incision really small, and this is much easier, you can see the your capsule erectus motions almost always pull toward the center. Otherwise you will run out. So Vision blue is really good if you need that. There's nothing wrong with that. That'll help you. So this capsule erectus forceps, this particular one's a Hoffman capsule erectus 23 gauge. They're different versions. I also have two different tips. One is a scissor you use, this normal kind of scissor on this one, and this one is a side cut scissor. You will see those instruments really, really helpful when you do some complicated cases such as PFV and pupillary remembrance, and you can use those to help you to manipulate to do the procedure better. Here's the lens aspiration. This is equipment instrument is just a retractor we all use. Pediatric cataract surgeon very familiar with this, and I use a irrigation sleeve over it. You can see this is a picture here. You'll put over it, so it's coaxial to do it. So you make an incision, and again, you pay attention to, I'm always holding the eye. You take advantage of that because the kid's asleep. And you start with the periphery. You use quick, like a sweep motion, sweep around over the periphery. Again, it's very important for pediatric cataract surgery. You really want to make a clean surgery, because they even you do a really good surgery, they still can rejuvenate the cortex. So yeah, this is just a quick showing all that being done. I've been doing this technique for past 15 years. I think it works really good. If you have trouble get the sub-incisional cortex, those old good instruments are still very helpful. Those are the IA, when I was resident, we're learning to the phaco. This is what we use for IA. Those have a 90-degree, a different angle of aspiration tips. You can help you get this cortex out. I haven't used this for many years, but it's always available. Here, sometimes I also do bimanual procedures. When I don't put artificial lens, I just do bimanual. You can do bimanual for even with lens. You just have enlarged incision. This is what I use. I like to use 20 gauge. Obviously, you can do 23 and 25 gauge. I tried all of them, but they're not as efficient. Use 20. Those 20 gauge is so efficient, gets the cortex out so much faster. So here, but most important is when you do I have this separate irrigation cannula, but those important is whatever gauge you use, you want to choose the same size of knife. You want to keep your wound tight, so you have a very steady anterior chamber. Hey, this one I use mostly 20 gauge. So the irrigation cannula is 20 gauge. It's just same. So here's a anterior capsular retracts capsule rexus here. This I use the irrigation cannula on my left hand, and my right hand I will use a retractor. You can use again 23 or 25 gauge, but 20 gauge works great. You're going to close your wound anyway, so you want to choose whatever is most efficient tool to get it done. So this gives you a nice anterior capsular rexus. Then you can do the same way. You oh, this is the same video. Apologize that. So lens aspiration, the same. You start from periphery and go all the way across. I like to do just the clockwise. You can do whatever works for you. I like to clean my subincisional first because that's most difficult part to do it. So advantage for bimanual procedure is you can switch hands. If you have trouble get your subincisional cortex out, you can switch hands, start from the other end, and that will help you take the cortex out. I think whatever way works for you is the best way to do the pediatric cataract surgery or any kind of surgery. You will develop your own way and find what is best, most efficient way to work with it. So you can, and for this particular case, I just take the out center, then do more on periphery. It's very important you keep clean more the periphery, make sure everything's clean before you move on to the next step. So then you can continue to do your vitrectomy, and this one is the same technique. I show lots of bimanual because I think more people use bimanual than my coaxial technique. So you can just continue. You don't have to take the instrument out. Just keep going. And after you do the cortical cleanup, you make a small cut in the posterior capsule and then do a really generous vitrectomy. Then you enlarge your posterior capsule just slightly smaller than your anterior capsule. And this, if you don't put the lens, it's fine. If you're going to put the lens in the future, you left a very good support. The future IOL implant. Here's my tray for, I have the 20 gauge. I use Constellation, but I have over the years, I used all kind of machines, Legacy, and most of my machine we use the Alcon system. I use the adults machine as well. It's all the same. The principle is the same. You just want to do the, here's the other next instrument on my tray is a injector for IOL. This Monica 3 system, this system can do both focus lens and back lens, so you don't have to different injector anymore. So if people use the Alcon lens, this one you just use different cartridge. Your B cartridge for your back lens, for the focus lens, and D cartridge for your back lens. I will show you. And also here, there's 3 little manipulators and a Kruger hook or Maloney, whatever it likes for you. So look, after I fill up the back, this is I have anterior and posterior both capsule open, but you want to inject this lens in the back. The key for this is you lift up your tip. You don't dive your lens into the vitreous. You actually lift the tip up and put in the back. One good thing about this Alcon lenses, there's soft. They're so soft. You open up very slowly. You do have time to position them. Here's the same injector. I used this is for putting the sulcus. Again, you fill up the sulcus, use this 3.5 keratin open back. This cartridge is bigger. You have to enlarge the one a little bit, but I was using the same injector. And this McPherson forceps is really helpful. You hold this trailing haptic, you position it in the sulcus. But if it did not go to sulcus, you can always use your little Sinskey hook or Maloney to reposition it. Here is I recommend you, and I always suture the wound. You are taking care of children, infants, toddlers. They don't really know. They're not supposed to rub the eyes. Even you make a small incision, I also close the wound. There's no downside to close the wound. So I'm always use absorbable suture here. This one's Velcro suture, tangle Velcro, needle holder, and tie-in forceps. Here I'm showing you, I place the suture first, then I wash out the viscoelastic. I use the Healon for everything. So I wash out the Healon in front and behind the lens, and you tie the wound, tied it up with this one stitch. This stitch will dissolve itself after week or two, sometimes a little longer, but it will be gone by itself. You don't want to put those kids to sleep again because of this suture. So that's how they look. And there's other things on my tray, like this little scissors. So you finesse this forceps. Some of the corneal surgeons like to use this to close the wound. Cellular dialysis spatulas will be useful if you do a traumatic cataracts or something. You need to make sure there's no clean the snake or position the areas. Here's some pictures. Tangle vacuum suture look like on the bimanual procedure. Here we'll go. Here's some very important technique points I figured out after many years through those surgeries. I think this will help you. You want to keep the eye fixated manually because you take advantage of patient sleep. You hold the eye. So maintain a very stable anterior chamber. This is the key for those. Pretty much key for pediatric cataract surgery. You want your chamber stable. You have stable chamber, everything's easy. Otherwise, you have a bouncing chamber. So tight fit wounds, that means your incision wound and instrument fit. If you do 20 gauge, use 20 gauge. You 25 gauge, 25 gauge incision. Minimize times and in and out the eye. This is very important that you don't want to go in and out the eye a lot because every time you go in and out, you change the anterior chamber pressure. Your chamber collapse, you posterior vitreous move forward, cause a big mess. So your instinct for inexperienced surgeon like my fellows, when we do surgery, if something unexpected happened there, first thing they do is take the instrument out. I said, oh, don't do it. So first thing you do is stop and look. Take deep breaths. And don't take the instrument out of the eye because you'll make a big mess for yourself. Okay. So that's a few things to remember. And also importance, your anterior capsule with macro incision in forceps. Try it out if you haven't done it. It's really great. Help you a lot. Lens aspiration, starting peripheral. This is very different with adults. Adults, you always do take your nuclear out and then start from center to the periphery. But children, they have very jello kind of lens materials, so you can have very quick clean up with just start on periphery. I don't do hydrodissection anymore. There's nothing wrong if you can do it, but I just found this really, to me, is unnecessary. With this peripheral clean motion, I can get all the corticals cleaned really well without hydrodissection. And also a lot of those pediatric eyes have some congenital abnormalities. They may have a weak posterior capsule or even an opening. If you do a big hydrodissection, you could push everything back into the vitreous. You don't want to do that. So I also continue my posterior capsulotomy with retractor when I'm already there with my retractor in my hand. I don't come out and fill up the bag with Healons and redo a posterior capsulorrhexis. I think it's an extra step unnecessary. But if you do that way, it's nothing really wrong. Because, we're surgeons, whatever works best for you. And that's the best way to do surgery. Here, I want to show a quick whole surgery for my IOL case. That super sharp blade opened the wound, and Helan, I use Helan, inject in the anterior chamber, and I open the anterior capsule with this cystosome. But if you can use the forceps already sharp to open this, you can even save this step. So, you know, look, the motion is really push, puller, because those capsules are so easy to turn out, very different with adults. So enlarge the wound. Notice this, I'm always, my second instrument holding this eye steady for me. And this for adults, you do paracentesis, you put second instrument. I don't think that's necessary for me, but there's nothing wrong to do that too. So here, see, clean the periphery cortex. And it's really, this is being edited, but the real surgery doesn't take much longer than this, really. The entire surgery typical take about less than 20 minutes to do it if you, and even with a posterior capsulotomy and angiotrectomy. As like we all know, it's not all about how quick you do surgery. It's about efficient, do a good job, give kids good vision and minimize the complications you have to go back in the future. So here I'm continue. I don't take my instrument out of the eye. I continue going to the posterior capsule and make a posterior small capsule opening and start doing vitrectomy. And after the vitrectomy, then I enlarge the posterior capsule opening to just slightly 1 millimeter smaller than my anterior capsule opening. That will make it easier for me to inject my lens in the bag. If you make it too big, sometimes it's a little hard to do it. You have to be, there's a small learning curve for that, but my fellow typical, after a few cases, they can do really well. It's just, you just keep those few key points I just gave you. This will help you out. So now, lens Helan in the back. Now I'm inject this lens. Really nice open up the back. It's very important. Your back open up well for you. So you put this lens in the back. Tip up, again, tip up. Don't dive in the vitreous, and put in the back. Then you position it nicely in the back. And you wash, then I put suture, then wash the Helan on top and bottom of the lens. Then here is how they look at the end. Okay, so let's see. Then here, iris hook, Dr. Saul mentioned, it's really important. You can use lots. Pediatric eyes doesn't really look that beautiful for you. Their pupil after dilation, they're 3-4 millimeters. You need iris hook to help you open. And this is an intraocular cautery. This will be very helpful when you do some complicated cases like this, PFV. You use iris hook, open up your wound. I'm not going to go through, this is a long case. I opened, I used the vitrectomy to open the anterior capsule, clean the cortical material. This is such a bad PFV. I wasn't planning to keep any of my lens materials there too.
Hey, Serena, can you hear me okay?
Yeah.
Okay, so I think that's time's up. Can you wrap in like next?
Okay. Yeah, I'm almost done. So I'm just showing you this quick, this is the cautery here. You can see how the cautery works then you'll be tracting it. Okay, so here, next one is, here's my tray. I have all the instrument on the tray if you want. Take a look, see if anything useful for you. Here's some pictures of my surgeries. They're not a particular pic, this is just daily work. Okay, thank you so much. Thank you, Dr. Song, and thank everybody listened. Hopefully you'll have a good day.
I'm going to go, for the next 15 minutes, I'm just going to go over the questions. Serena, can you hear me okay?
Yeah.
Okay, good.
I can hear you very well.
If I say anything that you disagree, or please chime in. So I'm going to just go over some of these. Actually, there were some excellent questions. So I just want to tell you that this is recorded, so it's going to be posted, and you're going to be able to play it from Facebook or LinkedIn. So please go back to if some of the questions that were asked, we actually addressed it. But the thing is that we went so fast that you may have missed it. But if I tell you that it was actually covered on a video, then if you just go back, you will see that it was covered. And also, I want to thank Lawrence Tika. He's our IT person, and he actually helped to manage. He helped to actually put this thing together, and he's one of those behind the scene guy that does an amazing job. So, Lawrence, thank you very much. So, um, I'm going to just read some of these questions. How technically do you enlarge the posterior capsulotomy with a vitrector? Just mechanically, or using the aspiration, or even other cuts? You know, when you're doing a posterior capsulotomy or capsulectomy with a vitrector, you're only using cutting machine. You're not aspirating because you do not want to cause any traction on the retina. So it's just cutting and suction motion, okay? And then, do you also clean the equatorial part of the anterior capsule? Yes. It is very important to remove, just like Dr. Wang said, it is very important to remove all the cortex, especially at the equator, because that's where the progenitors cells are. So you want to make sure you want to polish. After you finish, polishing the surface underneath the anterior capsule all the way to the equator, I think is critical. This is my opinion. That actually can't, I think that if you don't do a good job with this, the chance of opacity and even glaucoma, I think is higher. I think that's extremely important. After hydrodissection, do you aspirate the center of the lens and shape the lens into a cartwheel? You know, Dr. Wang actually removed the peripheral cortex first before removing the nucleus. That's exactly what I do. In adult patients, the lenses are stiffer, they're harder. So most people, for adult cataracts, they remove the nucleus. They remove the nucleus and try to collapse the peripheral cortex. But in pediatric patients, because the lens is so soft, it's actually, I think it's far more advantageous to remove the cortex in the periphery, especially the subincisional cortex, because that is truly the most difficult part to remove. So with the lens in place, it is easier to place the aspiration, the IA, right at the subincisional cortex, because the lens is actually pushing it in that direction, and it is actually giving you counter traction. So it is, remember, it's a traction and counter traction. You always want to think about that. So when you're cutting, removing anything, as you want to take advantage of that counter traction from the lens and the nuclear material to remove the subincisional cortex. So you want to, I typically remove the cortex first. Why do you use the vicryl suture to close the wound? Is it important? I have done surgeries in 40 different locations around the world. And I'm going to tell you, the surgical techniques are very, very different in different places around the world. As a matter of fact, I'm not going to tell you where, but in some places, they never use vicryl sutures because it is expensive. Tenno vicryl suture is actually very expensive, and they never use it, and even in a congenital cataracts. But the thing is that they do these surgeries in 5 minutes, and they do it very quickly, and they try to minimize a surgical incision site, and so they feel pretty comfortable not placing any suture. And in their, I think they actually have done, I think it was 200,000 cases of congenital cataracts, and they have never had a case of endophthalmitis. So after witnessing that, I'm going to just tell you that is it a must? I don't think so, but I do think that it's highly recommended placing a vicryl suture if it is definitely available. I would recommend, because the eyeball, the sclera tends to be soft and it tends to collapse easier, especially in patients with Down syndromes or patients with any type of chromosomal abnormalities or developmental delays. they're going to be pretty aggressive with eye rubbing. So I think that having the vicro suture there, I think just would make me feel better. Another question is that would the vicro suture cause scarring and white opacity at the surgical incision site? No, as long as you don't encapsulate and catch the conjunctiva and accidentally place the conjunctiva on the cornea, no, it shouldn't really result in significant opacity. And remember, just like Dr. Wang and I, we go from 12 o'clock incision. So the eyebrow, the eyelid covers that surgical incision site very nicely. Have you tried pars plana approach on patients whom you're not placing the IOL? Yes, I actually used to do a pars plana approach in the past, but I just don't feel that is necessary, in my opinion. Again, it's a matter of preference, and I think it's an excellent procedure, and it is a safe procedure. But just like Dr. Wang said, you want to make the procedure as simple as possible with less movement going in and out. So pars plana approach, I just felt that it requires an additional that's an additional surgical incision site. So I don't do it, but I've not going to it. I've actually those cases went beautifully. Do you use a triamcinolone after the procedure? Yes, I do. Sorry, excuse me. Um, sorry. Do you use triamcinolone and after the procedure? Yes, I actually injected intracameral and also subconj. Serena, do you use triamcinolone?
Only selected cases for traumatic cataracts, stuff like that. No, it really hasn't have a need for those kids do really well. So I do a subconjunctival injection of some steroids, solid measure.
So personally, if I actually take care of a lot of patients with the developmental delays. So these patients, I am concerned that they may not be able to place the eye drops. So I actually do intracameral, but I don't think it's essential. No, I think just like Serena, subconjunctival or just frequent eye drops of prednisolone acetate or phosphate every hour for about a week, I think is sufficient, because the intracameral triamcinolone is extremely expensive. And then let me just see. Post phaco is, do you perform iridectomy? No. Again, I think when I was in training 25 years ago, we used to do iridectomy on every patient because of the concern of the ankle closure, because of the iris bombay. No, these procedures, I think I've never, I cannot remember I have never regretted for not performing iridectomy. So, and Serena?
Yeah, only with very small eyes, when I put LL in the eye when they're like small diameter cornea, I do a peripheral PI, but most time, no, not routinely.
And then what is the best age of the implantation IOL in pediatric patient cataract surgery? I think we went over that. So please go back to the slides. And do you use triamcinolone, especially in rubella cases? So for rubella cataracts, especially in certain places like in Vietnam or certain places in Southeast Asian countries, South America, they have a fairly high cases of rubella because of lack of vaccinations. But I think it's improving. For those cases, it is very important that you make sure that you do not have any ladies who are pregnant or possibly pregnant in the OR. So I make sure that I remove them from the operating room. And I actually do use triamcinolone in rubella cases. But these patients do require closer observations after the surgery. How many days or weeks, baby? Okay. How many days do you wait between the right and left eye for bilateral cataracts? So, like I said, I personally, do I have anything against doing cataract surgeries on the same day for bilateral cases? No, I do not. If you look at the literature, I do think that we don't have enough evidence to really say, you know what, that is a malpractice. No, I don't believe that. And in certain situations, I think bilateral cataract surgeries on the same setting is warranted. But I would recommend that you change the drapes, change the IV bag, change the entire setting to reduce the risk of endophthalmitis in these pediatric patients. Um, um, but I personally typically wait about between 2 to 4 weeks between the cases, right and left eye. Serena?
I do 1 week apart, always to avoid amblyopia.
Okay, perfect. And then I'm going to see. I think that's it. So it is 9 o'clock. As you know, I'm like by the book. I actually like to just stay on time. And I know some of you guys, it's a very early in the morning, and some of you, it's a very late in the evening. And again, I love doing this, and I love, Dr. Wang. He's a very experienced surgeon. And if you are interested in hearing more about the congenital cataract surgeries, a particular aspect of the surgeries, or anything else, please post. Please, please. We have Facebook. The Orbis has a Facebook, LinkedIn, and other social media platform. So please let us know. And we read every single one of those comments. So please, if you're interested, we would love to do it again. And I hope you guys have a great day. Thank you.
Thank you. Thank you, everyone.